My name is Michael Watson, and I'd like to thank SAGES for the opportunity to present our work today, presenting the use of machine learning for predictive modeling after minimally invasive distal pancreatectomy. All authors have no relevant disclosures. Predictive algorithms are frequently used to assist surgeons and their patients with perioperative decision-making. The ability to predict postoperative outcomes based on preoperative factors can impact patient selection, management of patient expectations, and clinical decision-making to potentially improve outcomes. The goal of predictive analytics is to deliver precision medical care while avoiding a one-size-fits-all approach to patient care. The ACS NSQIP calculator is a commonly used risk calculator for morbidity, mortality, and length of stay. It has gained widespread use in the surgical community. However, there are concerns over its accuracy for certain subspecialty populations such as hepatopancreaticobiliary surgery. Therefore, many institutions are investing in procedure-specific calculators that in some cases are more accurate than the ACS NSQIP. Most risk calculators are created using linear or logistic regression models, which have traditionally performed well. However, there has been increasing use of machine learning techniques such as kernel regularized linear squares, or KRLS. These models may reduce misspecification biases that are associated with traditional models. At our institution, we have found that institution-specific models are more accurate than the ACS NSQIP, and our goal was to investigate the use of machine learning modeling for MIS distal pancreatectomy, which is standard of care at our institution. With this in mind, our hypothesis is that the use of machine learning techniques will provide more accurate models of postoperative outcomes than traditional techniques for patients undergoing minimally invasive distal pancreatectomy. This was a retrospective analysis of a prospectively collected institutional database. We included all patients in the database undergoing minimally invasive distal pancreatectomy between January 2008 and November 2018. The database contains 46 preoperative and perioperative variables, and outcomes of interest were length of stay, complications on the Claudine-Dindo scale, postoperative pancreatic fistula, and grade of postoperative pancreatic fistula as defined by the ISGPS classification. To perform traditional modeling, we first used bivariate analysis of the outcome variable against each preoperative or perioperative variable. Those with p-value less than 0.05 were included in multivariable logistic regression models. For the KRLS modeling, a similar procedure with bivariate analysis was used to determine variables for inclusion in the multivariate model. These were then used in a KRLS model. Traditional models and KRLS models were compared with R-squared and receiver operating characteristic, or ROC, values. All modeling was completed using STATA. In total, 379 patients were identified undergoing minimally invasive distal pancreatectomy during the study period. Selected demographics are shown here. Furthermore, outcomes for the entire cohort are displayed here. Mean length of stay was 8 days. 275 patients had a grade 1 to 5 Claudine-Dindo complication, consisting of 131 patients with a grade 3 or higher complication. 142 patients had a pancreatic fistula, comprising 38% of patients. The rate of clinically significant fistula, namely a grade B or grade C, was 20%, which is similar to other series. For predicting length of stay, we found that KRLS modeling was superior to traditional modeling, as the R-squared value was 0.7812 compared to 0.2042. Significant predictors of increased length of stay in the KRLS model were an emergency case, decreasing preoperative albumin, and increasing age. For predicting grade of complications, we found that KRLS model was superior to traditional methods with an R-squared of 0.7175 compared to 0.6220. Significant predictors of increasing complication grade in the KRLS model were increasing BMI and increasing diastolic blood pressure. When attempting to model postoperative pancreatic fistula, both models had similar predictive ability. ROC values were similar at 0.6052 versus 0.6222. When using KRLS to predict clinically significant postoperative pancreatic fistula, i.e. grade B or C, the ROC value did not significantly improve. Results of this study should be interpreted with caution in light of its limitations. This is a retrospective, single-institution study with a relatively low sample size. This may limit broad generalizability. Additionally, predictive variables used were only those readily available in our institutional database, and there may be other significant factors that were not included in this database. Lastly, with use of more sophisticated modeling techniques, there is a risk of overfitting to the model dataset, which may then lead to a lack of generalizability to other patient populations. In conclusion, incorporation of machine learning techniques may lead to improvements in the predictive ability of procedure-specific risk calculators, such as that for minimally invasive distal pancreatectomy. However, we did note that both traditional models and KRLS were poor predictors of postoperative pancreatic fistula. This may be related to a lack of relevant variables in the database, such as gland texture, pancreatic duct diameter, or underlying pancreatic pathology. Future predictive algorithms for subspecialty procedures may benefit from more sophisticated machine learning techniques such as KRLS. With multi-center validation, machine learning shows promise in creating more accurate procedure-specific risk calculators. Thank you very much for your attention, and I would like to thank all of my co-authors for their contributions to this work.